Hello, everybody. Welcome to this evening's distinguished lecture, Manchester on the Front Line in War, Disease and Disasters, with Professor Tony Redmond. My name is Bertrand Tate. I'm a colleague and friend of Tony, and I would say a few words to introduce him. But before I do that, I have a few housekeeping announcements to make. So the first one is, can you please switch off your mobile phone? And in fact, I should switch mine off. So switch off our mobile phones or put it on silent, because we are streaming this event and recording it. We're not expecting a fire alarm this evening. So if the alarm sounds, it's the real thing, and we'll encourage you to leave the building and to be evacuated by the staff in the auditorium. The facilities are through the theater doors on both sides, on the ground floor near the lift, should you require them. There will be time after the lecture for a Q&A, and Tony will be staying for a book signing of his brand new book, which I've just purchased. I'm very glad to say that I feature twice in the book, so I'm quite pleased. And that's everything. So let me introduce Tony Redmond in a very few words. If you're not going to buy the book, Tony is probably one of the most significant humanitarians that Manchester has actually hosted as a university, but also as a city. Tony is a Mancunian. Tony Redmond, as a humanitarian, had a career that began in earnest in the late 1980s, and he's still carrying on today. He has played a major role in setting up emergency medical teams in the United Kingdom and abroad, in China notably. He has intervened in a range of humanitarian sites. I've known Tony for 13 years, or a little bit more than 13 years, and together we founded the Humanitarian and Conflict Response Institute in 2008. And when we founded the Humanitarian and Conflict Response Institute, Tony was just coming back from the earthquake in Sichuan. A little bit later, he went to the earthquake in Haiti, and from there to other disaster zones that called on humanitarian help. Now, I've known many humanitarians, and I regard Tony as one of the most significant, because Tony has always brought a critical gaze on humanitarian work. He's someone to think with, to engage with, to reflect with. He set up a major NGO, or a non-governmental organization called UK Med. And UK Med is, if you want, what enables the NHS to deploy in times of emergency, most notably, for example, during the Ebola crisis in West Africa. So Tony Redmond is a friend, a colleague, is somebody I respect and admire. I think you're in for a treat, so please welcome Tony for tonight's talk.
Thanks, Bertrand. That's so kind. Thank you. And it's a great pleasure to be here. It's a great pleasure to see people in the room, in the flesh, after these difficult months. And hello and welcome to people joining us online. So I'm going to speak about Manchester on the front line in war, disease, and disaster. A little bit about myself. Bertrand refers to me as a Manchester nationalist at times, because I'm very keen to promote all that Manchester does. And I was born a few miles north of here in Failsworth, which was Failsworth near Manchester when I was born, and then it became Failsworth Oldham. Now it's Failsworth Manchester, and I think it's back in Oldham again. This is what you can see the picture of, is what I was told as a child was Failsworth Pole. But I could only see this obelisk, and as a child I thought it had some religious significance, because people used to stand and look up at it in awe and amazement. But it was only when I got my first pair of glasses I realized there was a clock on top. And in fact, people were just telling the time. And there is, in fact, a pole on the top of the tower, which was the original maypole for Failsworth. I understand many of you now are just starting out on your university career. This is me when I came to medical school in 1970. You can see the ravages of being a medical student and the effect they had on me quite quickly, and then the further ravages of working in the NHS over many years. But I really enjoyed coming to the university here in Manchester. It was quite transformational for me. I came from what people would consider now to be quite a poor background in Failsworth. People hadn't gone to university or into further education. And I got the opportunity to come to university here, and it was transformational, and I hope it will be for you. Whatever your background, this is a great university and it offers you huge opportunities. Having completed my medical undergraduate course, I then trained in what was a new specialty of accident and emergency medicine. Before that, what were called casualty departments were just run by the most junior of doctors who, the theory was, if you weren't sure what to do, then you would call somebody more senior. But of course, the fault in that logic is if you don't know what you're doing, you don't know when you don't know. So people realized we had to improve things, and so started developing a specialty of A&E. And I trained here in Manchester. I did some training in North America as well, where I actually deployed with paramedics in the States, which we didn't have in the UK at the time. You won't probably realize this, but the ambulance service in this country only joined the health service in 1974. Before then, it was part of the local council. It wasn't considered an essential health service. It was brought in 1974 while I was a medical student. I then was appointed a lecturer here in A&E in 1979, and then a consultant in 1984, professor of emergency medicine in 1995, and finally professor of international emergency medicine in 2005. So that's my work briefly. So let's talk about disease and my work in disease. And I'll try and give you some background so as it can increase your understanding and questioning of how people respond to these international emergencies. And by the way, if you've got any questions in the room, do ask at any time. I will certainly take questions later, but if suddenly something comes to you and you want to ask me, just put your hand up, it's fine. When I was a boy, the main railway station in Manchester was the central station, right in the centre of the city, just by the town hall. There it is. I actually caught a steam train there to go on holiday in the 1950s. Little did I know that 60-odd years later, I would be working in that same building as it was transformed into the Nightingale Hospital for the treatment of the COVID pandemic. Pandemic, by the way, meaning an epidemic is when there's an outbreak in a certain area. A pandemic, from the Greek, means it's everywhere. A global pandemic means it's everywhere. I don't know why they call it a global pandemic, but they do. It's like with earthquakes, the epicenter is the area above where the earthquake is, because the earthquake's underground. So the epicenter is the area on the surface nearest to where the earthquake was. But people now think an epicenter is a supercenter. So they talked about Wuhan being the epicenter of the COVID outbreak. Well, it was just the center of the outbreak. Okay, enough of pedantry, and let's move on. Manchester has a great history of dealing with epidemics and outbreaks of disease. This is Dr. James Nevin. He was the public health doctor for Manchester during the Spanish flu in 1918, 1919. It's a shame it got called Spanish flu because it was actually, as far as they can tell, it started in America. Donald Trump failed to realize that. It actually started in America, but the first recorded cases And when it became publicized was in Spain, because a lot of the reporting was suppressed during the First World War. So it got the name Spanish flu. But when it came to Manchester, this Director of Public Health instituted, for the first time largely, many of the processes that we put in place now to deal with it. And you will recognize some of them. We have to detect where the disease is, we have to test for it, we have to treat, but we have to isolate, and then we have to trace. You'll have heard about the R number, and what it basically means is if you have an R number, the reproduction rate below 1, then it is no longer spreading out of control. Anything above 1, before you can control that person and isolate them, they've already infected other people. So it's going out, and you've got to rein it back in. And you do that by isolation. We manage pandemics long before vaccinations, before any fancy apps on phones, anything like that. You manage them by isolation, by quarantine, coming from the 40 days that ships in Venetian harbours had to keep their crew on board before they could go onto dry land, so as they would not bring any infectious diseases on. So we know how to do this. The problem we had, from my perspective, is that, first of all, we had a 2-week run-in when Italy was completely swamped by it and we didn't do anything. And then secondly, we just did the test and trace, but you have to isolate people so as they don't infect other people. And the problem for people being isolated is they can't work. And so money, from my point of view, that was spent on technology could have been better spent on just allowing people more easily financially to isolate, and then that would have controlled the infection earlier and to a much better extent. But we are where we are. £37 billion was spent on testing. 37 billion. It cost $1 billion, to put a spaceship on Mars last year and fly a helicopter off it. So 37 times that. Anyway. So COVID-19, so-called COVID-19, coronavirus disease in 2019. And this was the Nightingale Hospital. You will have read lots in the press about the pros and cons, and people often think about the cons of the Nightingale hospitals. But let me give you some of the background thinking that went into it. Because I was asked to be the medical director of the Nightingale Hospital here in the Northwest. And I was asked to set up a 638-bedded hospital in less than 2 weeks. And we did it. And we did it because we've got experience of doing this in other countries, dealing with other outbreaks of infectious disease. And that's me with the team. And people came forward and volunteered. We didn't know what we were letting ourselves in for. The worry right at the start of the pandemic here was that we wouldn't be able to cope, that we couldn't give treatment, perhaps any treatment, to some people, and certainly the treatment we would like to many people, just because the numbers would be so great. And you've also got to remember that it's not just the patients who get sick. Having a medical or nursing degree does not protect you from becoming infected. And so the worry was that we wouldn't have enough staff, we wouldn't have enough beds to cope with all the patients that might come in. And so we would have to triage patients. We would have to sort them. This is a picture, a painting of Baron Larrey. Baron Larrey is one of my heroes. He was Napoleon's surgeon. And he was made a baron because he was so successful at being such a good surgeon for the troops, which really helped Napoleon's armies. But he brought in triage. That is, until then, the wounded on the battlefield were treated according to rank. So if injured came in, they would look at what rank you are. Oh, you're a general. Oh, come this way, sir. Private. Oh, well, we'll leave you. And that is what happened. He said, no, you'll be treated according to the severity of your injury, according to the severity of your injury and the likelihood that you might survive. But triage goes one step further than that in mass casualties like war or like an infection. That you might have to alter the level of care to you as an individual to maintain a reasonable standard of care to the population as a whole. And that's a really difficult concept to grasp, but more than that, to accept, that the public would have to say, well, in other circumstances, you might get an intensive care bed. But at the moment, we just don't have enough for you. So we're going to have to choose. And we're going to have to choose who is the one most likely to benefit from the treatment that's being offered. These are really difficult decisions. I've made these decisions in many places around the world. When I was working in Iran, I was presented with a whole range of patients, and they'd line them up for surgery. It was mainly to have amputation of their legs because they'd been crushed in an earthquake. Their legs were black and they were infected, and these people were really ill. And if you remove the leg, then you certainly take away the source of infection, the source of damaged muscle that stops their kidneys working. But you have to do it quickly. But they presented patients to me. The first ones were older, they were all male, and their kidneys had stopped working and they were unresponsive. The chances of them recovering, even if we did the surgery, was very low. Going down the line, I saw younger people who were awake, very, very ill, very toxic, very septic, but they were awake and their kidneys were still working. You could see they were still passing urine. Some of them were young men, some of them were young women. And so I made the decision to move them forwards and say, we can't operate on everybody at once. We will operate on those who might get the best from our treatment. And so we did that. And the ones we operated on lived. Then thought, now we've got time to go back to the ones who were presented to us first, who were very sick, but they were now dead. These are very difficult decisions, and I still think about it, and it still troubles me. But we were in a position with COVID, those of us in more senior positions, about would we be facing a similar problem here? So there was a rapid movement to open up more beds, open up more intensive care beds, and to, if possible, avoid having to make any such decisions. And if we have to make them, that they would be for as fewer people as possible, and that state of dire emergency would be restricted to as short a time as possible. That's what we faced when we started to set up the Nightingale. We had to move quickly, and decisions made in these emergencies are not always, in hindsight, shown to be the best decisions. You have to do that. When I work in emergency departments and people come in and they're very ill, you don't have time with the very ill people to go through all the tests that you would like. You just have to make your best guess and try your best, and then keep re-evaluating. So for us, in the Nightingale, we adopted General Powell's, it's an American general. It's controversial in many ways, but in this respect, he came up with the 40-70 rule. And the rule states that you need between 40 and 70% of the total information you would like to make the best decision. You need a minimum of about 40%, because otherwise you're just taking a stab in the dark. But if you wait until you've got 70, 80, 90% of the information, you've been overtaken by events. Had we waited to say, oh, well, wait a bit longer, do we set up a Nightingale? Do we wait a bit longer? It could be it was too late now. People were dying in hundreds and thousands, so we had to make a decision to go with it and get this balance between perfection and speed. We do that when we deploy to sudden disasters overseas. Earthquakes happen. They ask for help. If you say, well, we'll wait and see whether they really need international help. I know they've asked for it, but we'll wait and see, because it costs a lot of money to mobilize the team. We'll wait and see. If you wait until it's absolutely clear that the hospitals are not coping. Many patients who could have been saved have already died. So if we get the call to go, we just get on the plane and go. It might be, sometimes we've been turned around in midair and it come back. Sometimes you get to the airport and say you're not needed. It's absolutely fine, no regrets. But if they do need you, you are there as quickly as possible. So that was the thinking behind setting up the Nightingale. But even within that short period of time, two unprecedented and certainly unforeseen events happened within society. Number one, the hospitals managed to create more beds and intensive care beds in a record number of time. They cleared things out. It was an enormous effort, a wartime type effort to create more beds. And as you can see here from A&E attendances, people stopped going to hospital. Hospitals became empty. People, a large part of it was altruism on behalf of people. We don't want to overload the hospitals, but people were frightened of going to hospitals too in case they got COVID there. So by the time we opened, we knew that what was set up to deal with a catastrophic amount of casualties, amount of infected people was no longer needed. So do you just mothball it and leave it? Well, decisions across the country changed. Some never opened, some only saw a few patients. What we thought with the thing to do is just adapt. What is the need now? And the need actually was to decompress the hospitals. So if they're managing on intensive care, you've only got so many beds. You need to get them off intensive care. You need to get them out. But they couldn't go into care homes because of COVID. Some of them, they'd come off intensive care. They were quite elderly, and they couldn't go home straight away. So we put them into the Nightingale. Don't worry about the graph. What it's saying that from our first patients, you will see that they were all very elderly. Our average age was 85. We had patients over 100. They all survived. Our youngest patient, I think, was about 70. So these were elderly, frail patients who had recovered from COVID. Some of them had been very sick, but didn't need an acute hospital care, but couldn't go to a care home, couldn't go home, so they came to us. So that was the first phase. The second phase, after we decompressed that, was to say, well, what about freeing up all the other beds so as the NHS can get back to normal? So in the second phase, we took patients who didn't have COVID, but were frail and needed rehabilitation. And so they could get them out of the hospital into the Nightingale. And then they were managed by general practitioners, community nurses, physiotherapists, occupational therapists to get them home. So that's what I'd like you to think when you hear about the Nightingales. They were there as an insurance policy. Nobody likes paying an insurance policy because they think, well, I never used it. Well, exactly. Your house didn't burn down, but you still need the policy there. Metaphorically, the COVID house didn't burn down in the hospitals, but it came very close. So why were we, when I say we, why were we asked to respond? Well, as Bertrand said, I set up a charity called UK Med, international medical charity, which sends experts and medical teams all over the world. But what's unique about us is that we are based here at the university. It's a charity, an independent charity, but the university houses us and supports us. And we sit alongside, both metaphorically, but actually practically, on the same corridor as the Humanitarian and Conflict Response Institute. Because both Bertrand and I share the concern that people like me who deploy need to have their actions scrutinized, criticized by academics so as we can get better at it. We have to question what we do. And academics, people like Bertrand, need to understand from those who deploy what it's really like. Why did you do that? Why did you make those decisions? Why did you set up the Nightingale? Why did you send a team here? And this symbiotic relationship has proved extremely fruitful. And we're unique in this setup, unique in the world. But we were asked to set up the Nightingale to support the NHS because of UK Med's experience of outbreaks. We've been responding to a large number of these over the years. But Bertrand mentioned Ebola in West Africa. We coordinated the NHS response to Ebola in Sierra Leone from the university here, from HCRI and UK Med are based. And we sent hundreds of people over, and we set up with the British Army Ebola treatment centres in Sierra Leone. But equally, we've managed Ebola outbreaks in the DRC. We've managed the diphtheria outbreak with the Rohingya in Bangladesh. We've managed a measles outbreak in Samoa. Tragic, actually, because of misinformation about vaccinations. That small community, their young people, were not vaccinated against measles. And what people don't often appreciate is that measles is a benign illness here because of our vaccination program. But it's not in unvaccinated communities. It has a mortality rate, but tragically has an incidence of brain damage. And so we sent a whole team in there to start the vaccination program, to train people, and got it back down to reasonable levels. For COVID, UK Med has been working all over the world, supporting local healthcare workers and systems to set up their own COVID treatment programs, how to use PPE, how to have proper infection and prevention control, and how to physically set up COVID treatment centres. And we're still doing that alongside our other work we've just set up an office in Yemen, for example, to work in that sort of environment. So that's our work on infections. I'd like to move on now to disasters and just give you a background as to how I got involved in disaster response and to see how it fits in to the NHS work and emergency work in general. Now, as I say, I started out as an accident and emergency consultant, but I became very interested in pre-hospital care. That is the management of patients even before they get to hospital. And so I set up what was called the South Manchester Accident Rescue Team, or SMART. In fact, we came up with the word SMART first and then thought what words will fit the acronym because we liked it. And that proved very successful, and it set the model for all the international work we do now. SMART said system of volunteers, because hospitals talk about flying squads, but hospitals just look after the hospital. Once you're outside of the hospital, whose care are you under? Particularly, even when we didn't have advanced training for paramedics, they just transported you into hospital. What if you were trapped? There was a child trapped on railings within railing through. Who's going to manage that? I've operated on someone's abdomen there on Princess Parkway. When the car went round and hit the central reservation that went right through them, and they're impaled on it. How are you going to get them off? What are you going to do? You can't use cutting device because you'll make shish kebab or something. I mean, you can't do it. So, who's going to do it? Whose responsibility is it? So we set up this team. You say, well, call a surgeon out from the hospital. But the surgeons in the hospital are operating. They're doing clinics. So we set up a separate volunteer register of volunteers, senior nurses, doctors, who would, in their time off, volunteer to be on a register, to be called out for the South Manchester Accident Rescue Team to go and support their colleagues in the community. And that's the model we've used and we use now. We have a much bigger register now, but it's the same principle. Many of our volunteers are in the NHS. They're seconded from the NHS, and they volunteer to do all the training with us. We raise the money for the equipment. We raise the money for the ambulance. We raise money to equip SMART. And we raise all the money now for UK Med and for all our international work. It's been the same model. It's just got bigger and bigger. And also, I thought we really need to have paramedics in the United Kingdom. So this was an article I wrote in the British Medical Journal to start the conversation going. And we raised the money to buy defibrillators. We bought 2 defibrillators and put them on ambulances in Stockport. This is in the 1980s. There were no others around. There was an ambulance manned by doctors in Northern Ireland and one in Oxford. But we trained the ambulance men here in Stockport and showed that it could work. We could train them. And the ambulance staff did all the training in their own time. They got no extra pay. We raised the money for the equipment, but they deployed and we could show that it worked. We had a spectacular, one of the first patients that we resuscitated from cardiac arrest was actually in a working men's club. He was a trade union leader and he had a heart attack in there. And the ambulance could resuscitate him. He would have, had we not, the month before we had this project, he would have, because we have a cardiac arrest, you die, you are technically dead, he would have remained dead. But in fact, he recovered fully and went back to his family and work. And they raised lots of money for us because of that. And so we expanded quickly, and here in the Northwest, we very quickly had the biggest paramedic training scheme in the whole of the UK. The rest of the country caught up, but for a while, we were certainly the biggest. Having set up this team, we now got some sort of national notoriety, if you like. Then this earthquake happened in Armenia in 1988. And we were asked by the British government to take the team to the earthquake. Now, I'd never been to anything like this. I'd worked in A&E. I've seen some really difficult, some shocking things, and I thought I could cope with it, but I wasn't prepared for the scale of the destruction that I saw. But we took the team. Official figures say over 25,000 people perhaps were killed. That's only official bodies identified and so on. We thought it could have been 2 or 3 times that. And there you can see the scale of it. These are all coffins. Just so many people killed. On our way back, we were then diverted to an air crash in Scotland, the Lockerbie air disaster, the bombing of the Lockerbie plane. So in 1 month, I'd gone from an A&E consultant trying to improve pre-hospital care in the Greater Manchester area to the largest sudden onset disaster so far of the 20th century and the largest terrorist attack in the UK. So it was quite transformational again for me. I have to say that I was quite overwhelmed by it and felt it would be perfectly justified to never do this work again. I found it very, very, very difficult. But I gradually thought it through and I thought, well, if I am going to do it, I have to do it really well. I have to train properly. I have to work with the international community. And you have to make it your life's work. It can't be something you do on the side. So that's what I did. Now, if you're thinking about emergency medical aid, there are some points which I learned from going to Armenia, which are still very relevant today. You need to respond to assessments. Don't just send things. People will do assessments and tell you what is needed. For us as doctors, is it medical or non-medical things that they need? They don't always need antibiotics, for example. And if they do need medical things, is it just the antibiotics or the surgical equipment? Do they actually need you as a person? And you can't do everything for everyone, so target. Makes you just think, well, we can do this really well, so we'll target it and we'll do the best in that particular field and work with local people. Things improved after Armenia. We set up the United Nations Disaster Assessment and Coordination Team. I was a founder member. A disaster occurs, you send a small team out, you do an assessment, and then you publish what is needed. You work with the local authorities so as you don't just get unwanted aid coming in, because people have to deal with it. It's not benign. Resources are diverted to deal with it if it's not needed. And then INSARAG, the International Search and Rescue Advisory Group. Lots of people turned up in Armenia saying they were search and rescue teams. I met many who were literally one man and a dog. It's a search and rescue dog, you know. Well, so they set up a much better system of training and accrediting search and rescue teams. They did extremely well with it. And then we expanded. In 1990, we went to a large earthquake in Iran, a much different team now. We had no diplomatic relations with Iran. As a country, I had no visa or anything, but we were asked to go by the Iranian Red Crescent. We were very well received and very well treated, and we worked well there. So well were our relationships that, in fact, they invited us back the year after to set up a tented field hospital on the Iran-Iraq border after the first Gulf War to deal with all the refugees that were coming in. We dealt with a typhoid outbreak there. We dealt with malaria. We dealt with landmines. First two patients that we had were little babies who looked to me to be in the end stage of meningitis, and I thought that they would die. But they didn't. We treated them, and they survived, and they made a full recovery. And it was such a huge lesson for them. I was basing my opinions on what I would expect from working in the UK, where children are generally very healthy, very well fed, and they do become so ill with meningitis, it's because they have an underlying vulnerability. Not so there. These were undernourished children. They were dehydrated. And they responded immediately to a little drop of medicine. We just put general antibiotics into them and intravenous fluid, and it taught me a big lesson. And then since, these are just some of the deployments that came to my head when I was preparing this talk. We'd been all over every major earthquake since, and many conflicts and so on. One of which was the earthquake in China. The reason why I want to draw this to your attention is the fact that we do a lot of work with the emergencies, but a lot of the work we also do is in the rehabilitation afterwards. We had a surgical team in China for about a month supporting the surgeons in the very remote areas. We had a 2-year spinal injury rehabilitation program. And that's the relationship between the emergency treatment and the follow-up rehabilitation treatment. And I'm a visiting professor now at the University of Sichuan, and we also help the Chinese develop their own national emergency medical teams. They have 5 now, fully equipped, and they deploy outside of China to support their neighbours. Another important event was Haiti in 2010. I draw this to your attention because more and more people were becoming interested in sending medical teams, when in fact it led me to ask, are good intentions enough? Is any help better than no help? I worked there for 3 months. Well, I personally worked there for a month, but we had a team there for 3 months delivering surgical care. And then after that, Bertrand led a team of researchers that went back in to review what foreign medical teams had done. And we came up with some disturbing figures. Amputation rates range between less than 5 and greater than 45%. One team, 85%. So it's the same population, but it was the experienced teams who could save limbs more than the inexperienced teams who just went straight to amputation. And those teams who were doing high amputation weren't making any medical records. They weren't getting authority off the patients. They weren't even authorized to practice in that country, which you should get. And so working with other experts, we worked with MSF, with the Red Cross, we worked with the World Health Organization. We had a meeting in Cuba, in fact in the Caribbean, where we established the Foreign Medical Teams Working Group, which I was the first chair. And we came up with this classification and standards to which emergency medical teams can be guided to make sure that you are properly prepared, equipped and trained. But people think, oh, well, it's just an emergency, you just go and do it. They're all predictable. The consequences of earthquakes are known, the consequences of tsunami are known, they're all known. So if you're going to go, start preparing now and get trained and properly equipped. And also with the Red Cross, we publish guidelines on the appropriate amputation and limb salvage during wars and during disasters. So huge improvements. I led a team to the aftermath of the typhoon in the Philippines in 2013. We'd just published the classification and standards when we arrived in the Philippines, and on arrival, I was asked by the authorities, are you classified? What is the standards? And I wrote that book, but I was very pleased to be asked how quickly the standards got out there. And then a British warship was in the area at the time, HMS Daring, and we hitched a ride with them because they could go out into the South China Sea where no other humanitarian aid workers could get. They had speedboats, they had a helicopter, and so we could go and do clinics all over the islands, which were terribly devastated. The next earthquake was in Nepal in 2015, the next large one, and we sent a team there. But now, because the standards had been in place, WHO had a coordination cell, so you just couldn't turn up, you had to come through WHO. This virtual on-site operations coordination center, sorry about the terminology, but the government of Nepal put on the web what it wanted, what it needed, and you made an offer, and then they decided whether they needed you. There were no record of any inappropriate surgery during Nepal. The standard was very high because teams who were not properly trained or were kept out. 3 teams managed to sneak in by saying that they had a capacity that they didn't have, and the Nepalese sent them home. So things have changed enormously and enormously for the better. And the government did its own review here and found that they'd been sending lots of search and rescue teams in the past, but medical teams were highly cost effective, 100 times more cost effective in terms of saving lives. And so they funded a national team. And we have, as well as the work of UK Med that sends its own teams, we have a government emergency medical team now, a national team. The medical staff all ran from Manchester here, and we send the teams all over. To start winding things up, I'll talk about war. I've vetted the slides as much as I can, and I hope there shouldn't be any that I would consider too distressing, but it's just to give you just a little warning there, and if I sense that they're too difficult, I'll move quickly on. Bit of history. This is the Manchester Ship Canal. What's this got to do with war? Well, Sir Robert Jones, there's Sir Robert, was appointed superintendent, medical superintendent of the Ship Canal. And he set up the whole idea of casualties and so on, casualty clearing stations. So what we now have as casualty departments in the UK, we're actually, a lot of that approach and of transport and the interconnectedness of casualty centres was set up to deal with the terrible injuries that came from the building of the Manchester Ship Canal. Why am I telling you this? Because in World War I, he was appointed one of the Surgeon Generals in charge of the Army medical response in the First World War. He was the nephew of Hugh Owen Thomas, a Welsh surgeon. He was a bone setter, he called himself, but he was a surgeon, who had devised the Thomas splint for the treatment of fractures of the thigh bone, of the femur. Why is that important? Well, bones, particularly thigh bones, are full of blood. If you break your thigh bone, it bleeds from both ends. And if you don't put it back straight, you can bleed to death. If you fracture both your thigh bones and they're not straightened and put back together very quickly, you will bleed to death. So Hugh Owen Thomas had developed this simple splint that you pulled the leg, the bones snapped back into place, the muscles, they'll pull them together, and you kept it all in place in this splint. His nephew introduced it into the management of injuries in the First World War and reduced the death rate from fractures from 80% to 20%. Such a simple thing, and it is still reckoned to be one of the most effective surgical procedures ever introduced. And it's simple, and it comes from the Northwest. Robert Jones had a patient called Harry Platt. Orthopedics comes from the Greek ortho, straight, pedic, children, straight children. It was a specialty developed to treat the bony deformities brought about by TB, tuberculosis of the bones, which was very common 100 years ago. And Harry Platt had TB of the knee and was treated by Robert Jones and was so impressed, he went on to become an orthopedic surgeon himself. One of his many claims to fame was he invented the concept of a fracture clinic. If any of you have broken a bone and you've been seen in the fracture clinic, Harry Platt from Manchester in Ancoats Hospital, where he thought, well, no, we'll treat fractures separately. And it's all around the world. And I've worked in so many countries, and it's always fracture clinic in English. And I think, thanks, Harry. He was asked by the government to look at what were called accident services. And then a casualty service should be altered to accident and emergency, and that injured patients should not be taken necessarily to the nearest, but to the most appropriate hospital. Looking at the second bullet point there, we have now got the idea of trauma centres in. It's taken a long time. There was a resistance to it, but we've got them in, and we have trauma centres across the country. But what about accident and emergency? Well, thank you, BBC. They don't seem to have registered that the name changed in 1962, and they still call it casualty. I've tried and tried writing in, first of all, writing to the BBC, and then when the email came, I thought, this is good, I can really bombard them. So I sent, and it's like, no, they eventually, they came to see me at the hospital. I think they were just getting fed up. And I think they wanted to see what this nutter really was like. So I said, look, you know, it's accident and emergency, and we do lots and lots of things. It's not like the program that you present. You know, we do very sophisticated resuscitation. It's really, you know. So he said, oh, yeah, well, give us some things. And I said, I can give you lots of cases to put in there. And then as we're finishing talking to the staff, he said, is there any amusing stories that are suitable for early evening BBC TV that you might be able to put in? So I said, no, I want you to get the serious stuff. And then one of the nurses said, tell them about the turkey at Christmas. What? I said, oh, well, we were really busy. I'd been up all night dealing with a major road accident. And then there was a big queue of patients waiting to be seen, so I will have to deal with it. And the receptionist came in and said, would I go and tell this this woman that this was not the place to come and ask for cooking advice? What? She wanted to know how long to cook the turkey for Christmas dinner. And she'd come to A&E. So I went out and I said, this is accident and emergency. Well, she says, well, if by accident I do undercook it and everyone gets food poisoning, that will be a big emergency. So I said, 20 minutes a pound, and I had 20 minutes. She said, I knew you'd know. At which point the nurse and receptionist were horrified. Anyway, you can see where this is going, because we all tuned in to the Christmas episode of Casualty, where I was promised everything I'd told them would be included. And the only thing they included was the turkey story. Moving on into what I worked in the war in Bosnia from 92 to 96, and then on to the war in Kosovo. By now, in order to get teams going in and out on a regular basis, because we were supporting the hospital in the centre of Sarajevo, we had to broaden the net and get people in from across the whole of the UK. So we set up UK Med, evolving it from SMART. It's not part of my lecture. Welcome back, everybody. Okay. For a talk on emergencies, I couldn't really have planned that better, I suppose. And I did get one question which I've answered. The Turkey story is true. And I'm still cross about it. Anyway, so bring the mood down a bit, I'm afraid, going into conflicts. Whilst we can set standards and everything for working in sudden onset disasters, it's much more difficult once you get to work in conflicts, because do you try and deliver aid on both sides? I worked mainly in Sarajevo. I did work on the Serb side with Croats, so I worked, but I thought the greatest need was in Sarajevo and with the Muslim community that were under this siege, which did bring me some significant problems. I got put on a Serb watch list. I was stopped at checkpoints. I was held a few times, and our equipment was stolen by armed soldiers. It got very difficult. You can argue, and people do, about you should be entirely independent and neutral. I understand all those things. I was drawn more to who I thought had the greatest need. But there are issues around responding in conflicts, whereas in a sudden onset disaster, there's an earthquake or whatever, you know who's in authority and who's asking you to work there. But if you go to work in Syria, or you go, who has the right, who are you working for, under whose authority? How do you do it? You just have to make the best decision that you can, and of course it's dangerous. I was shot at too many times, and so I had some really close shaves. I mean, literally at my feet, and one that just went just over my head. So it's not without risk, and if you're taking teams in, you've got to explain the risk to them. But even then, do you ever really get over to them the chances they're taking? But people came forwards and volunteered. And then even the getting in and out of Sarajevo was difficult. The airlift we called Maybe Airlines. I've got a stamp in my passport that says Maybe Airlines, because some of the soldiers would stamp it with that for you. Maybe you would get a seat on it. You had to fight to get onto it, because there was no real proper booking system. And if you did get onto it, it was being shot at. So so maybe you'll get on, maybe it will take off, and maybe you'll land at the other side. The Italian plane that was my first time I went on the airlift was shot down, and everyone was killed the next time it went in. So this was a whole different ballgame about working in conflicts. But we managed to run a full surgical program throughout the war. And then I moved on to Kosovo. When NATO went in, I was asked, I'd already worked in Kosovo at the very start of the Balkans War. Then I was asked to go back and head up the hospital there that had been completely trashed. There were feral dogs eating. I mean, it was terrible. I'm sorry. These things are upsetting. They turn the power off in the mortuary. There were gunfights. They called it casualty. There were gunfights, and I even had a Serb patient, who'd been machine gunned in the street by the Albanians. She was still alive when they brought her in, and we had to operate on her. And she said, "You're not going to operate on me. This hospital is now full of Albanians who will finish me off. I want to go to Belgrade in Serbia for my operation." But I knew she wouldn't make it. So I said, "Well, we'll just have to carry on with the operation." She says, "No, you don't." She pulled the covers back, and she had a grenade. She said, "I'll take you all with me." Well, that's what the translators were saying. So he had to make a decision straight away, and I said, well, you know, we're just going to have to operate. So I said to the anaesthetist, you're just going to have to sedate her. We'd got the army in. You're going to have to get hold of the bomb when she goes off to sleep, and we'll just do enough surgery to stop the bleeding and then take her quickly to Belgrade, and she will wake up in a Serb hospital, and they'll finish the operation there. And then I heard a voice from the back where an American doctor who was actually working with us as a volunteer said, you can't do that. She hasn't given her permission. It's against her human rights. What would you do, by the way? You're me now, patient, bleeding to death, holding a grenade. You want to put her to sleep through the operation, and a doctor says she's not given permission. You can't operate on her without her giving permission. Would you say, okay, we can't operate? Boom. Well, because the one thing that crossed my mind, well, she's bleeding heavily. I could just wait until she goes unconscious. But by then she would have died. She would have bled too much. Anyway, I went ahead. I told them to sedate it, to get the armor, and then took her into theatre. I ignored what the American doctor came, who did actually apologise later and said that she was just too stressed by the whole situation and wasn't thinking. And she then became a very successful humanitarian worker and has worked all around the world. From Kosovo, I went to the civil war in Sierra Leone. And so you can see a whole succession of these events. We also ran training programs for Syria. A particular problem in using people being exposed to noxious gases, chemical warfare, but also being injured. How do you manage them? So we set up whole programs. Again, you can see the pattern of being able to manage in PPE, both for dealing with infections, but also for dealing with contaminated casualties. Worked in Gaza, just the same. Just like in China, surgical team in for a short period, then a rehabilitation team in for at least 6 months after that. Okay, some points now just to ponder as we draw it to a close. What I've been describing would come under the heading of humanitarianism. For me, it historically draws on the concept of compassion, individuality and reform. That's what we tend to think of it. Certainly in the UK, Wilberforce, the abolition of the slave trade prompted these people to give of themselves and look to right great wrongs. By the middle of the 19th century, the Red Cross was set up, the Geneva Conventions, the further development of international humanitarian law. In practice, though, now it's often used to just distinguish emergency aid from development aid. They say this is humanitarian, this is development. I think that's a false dichotomy, and they should all be working together. You can download Dunant's book, translated into English, from the Red Cross website. It's a wonderful read, and it gives you a good insight into the development of modern humanitarianism. But technically, if we're talking about humanitarianism, we must adhere to the Geneva Conventions, international humanitarian law, and these principles of humanity, neutrality, impartiality, and independence. And that's where in conflicts it can be difficult. Humanity relieves suffering wherever you find it. That's the paramount principle. But how do you remain neutral? How do you impartial? What if you are in Sarajevo and the suffering I saw was abhorrent? And I'd worked on the Serb side and see they don't have the same needs. They're not suffering in the same way. Whether there's this. Can you remain impartial? I was funded by the British government to do it. I designed the programme, but was I independent if I was funded by the government? I'll leave you to think about it. I still think about it. And then humanitarianism, we have the celebrity humanitarians. I don't wish to be too hard on that, but it seems that you can just call yourself a humanitarian. I listened to David Beckham on Desert Island Discs, who was introduced as footballer and humanitarian. I don't see you in many earthquakes, but anyway. But it's interesting that or humanitarian activists don't do bad things. Okay. But it's not all benign. When I was in Haiti, John Travolta, great dancer, confession, I did buy a white suit. My wife had the same reaction. I only wore it once, and she wouldn't let me out of the house. But great dancer, flew his own plane into Port-au-Prince in Haiti at the airport, blocked the tiny airport, no other airplanes could come in, they're all hovering. Did an interview for the international press, and then delivered over 200 much-needed Scientologists to carry out healing by touch. Now, you may think, oh, well, that sounds quite funny. It's not funny, because you're dealing with a very poor country, a country that has voodoo in the wards. We saw them practice. We gave patients antibiotics and things, but they also got voodoo, and it was quite interesting to watch. So people coming to say, I can heal by touch, it's not benign. It has an effect. So I have to be very careful about the sobriquet of being a humanitarian. But here in the Northwest, we have a particular link to the development of humanitarianism. This is Abraham Lincoln. There's a statue of him here in the city centre. Why that? Because at the height of the American Civil War, when the ports in the South were blockaded by Lincoln to stop the cotton being exported so they could starve out the people in the South, no cotton coming out, no cotton coming into here to support the cotton industry. But the working people of Manchester, who were now starving because there's no welfare state, who couldn't work because there was no cotton, wrote to Abraham Lincoln and said, in the name of the working people of Manchester, essentially, you carry on what you're doing. Your cause of what you're doing is much more important than our suffering. A wonderful thing, and it makes me so proud of the people of Manchester. And Lincoln wrote back in fulsome praise of the people of Manchester. And when the town hall reopens again in a few years' time, you can see the letter there. They've got the letter from Lincoln there. But they also set up a relief committee, the Lancashire and Cheshire Operatives Relief Fund. And in today's money, raised over £45 million and distributed food and aid. Across the British Empire, they got international funds in, very much like Live Aid. They really mobilized people to help. And importantly, they distributed the aid according to scientific values. Even at that time, they could measure expired carbon dioxide. And this chap, Edward Smith, could measure your calorific requirements. At medical school, I was taught that men and women have different calorific needs. That's not what he found. And that work was done here in Manchester. That's not what he found. He said the calorific needs are proportional to your size. So it's likely that men, in generally being bigger than women, are likely to require more calories, but not necessarily. It wasn't a gender issue, it was a size issue. But it's interesting how that got transformed now into people thinking, oh, well, men require more calories than women. No, we don't. And then Florence Nightingale. Florence Nightingale didn't like the Red Cross, and it's important to appreciate that the different sides of this. She said that Dunant, by setting up this charitable organisation that would go into conflicts and treat the wounded, would allow the warring factions just to carry on killing each other. The same was said of Bob Geldof with Live Aid, that if you go and give all this money to Ethiopia and feed the people for them, then the government will just carry on with the war because they don't need to feed the people, which is true. But people still starved, as people still needed food. The same for me in Sarajevo. It's been calculated that if no aid went in, the Serbs would have taken over Sarajevo very quickly, that maybe a few hundred, maybe a few thousand people would have died, and that would have been the end of it. But by supporting the people in Sarajevo, the war went on for years, and many thousands of people died. But there are things that people are prepared to die for. The other thing, just to get a plug in for Florence Nightingale, we all know about the Lady of the Lamp and the Wards. She was a very accomplished mathematician, and this is her diagram. Look at these very sophisticated pie charts. She didn't invent the pie chart, but she popularized it. So she could show government ministers and armies how infectious diseases were reduced the moment she started introducing her hygienic methods. She was quite something. The other things I want you to just think about is people's worry about the unburied dead. The unburied dead bodies, are no threat to you physically. They do not cause epidemics. Everyone thinks they do, particularly the media. You think that the casualty program hate getting letters from me. Sky News, whenever they say, and there's been an earthquake, and there's a fear of an epidemic. No, there shouldn't be. Don't you read that? I think they take bets on how many seconds it will be before Dr. Nutter emails in to say that, because it doesn't. You just die. Dead bodies are very distressing, and they're very smelly, and people get very upset by them, very frightened by them. But you just die. They don't contaminate the water system, they don't do any of those things. They're only a problem when you've not died suddenly from a disaster, but you've died from an infection that can live on after you've died. And the fluids on your body surface can be infective. And the classic ones are viral hemorrhagic fevers, they're called. Ebola is one. That will live on in bodily fluids. That's why they had to change burial practices in West Africa, because the bodily fluid, and because people bleed freely from Ebola, they get very easily contaminated. And cholera is another one. The Vibrio cholera lives on in the fluids afterwards. But other than that, just a sudden onset disaster, the bodies will be very distressing for you, but they will not pose any actual physical threat to you. We talk about natural disasters, but are disasters really natural? I'd like you to think about that. My first earthquake I went to in Armenia killed maybe 50,000 people. California, Loma Prieta, the year afterwards, a stronger earthquake killed 63. The difference was architecture. You could build structures that could withstand the earthquake. Look at Melbourne now. That earthquake there is not much weaker than the one that struck Haiti in 2010, though it's killed maybe 150,000 people. Nobody died in Melbourne. That's architecture. And architecture, the quality of building, is a function of how rich you are. And so the poor are always the most vulnerable. So I'd like you to take this away with you. There are no natural disasters. They're all man-made. It's the poor that are most vulnerable. And poverty is produced by politics and economics. People don't choose to be poor. People are made to be poor or kept in poverty. And we can change it, and we should change it. Disasters are getting more and more frequent, but the death rate is going down across the world. The problem with that is not if you're poor. So it's much more disparate now. These sudden onset disasters, even the work in emergency departments, it is the poor that are the most vulnerable. Those from poorer economic backgrounds bear over 2/3 of the world trauma, the world injury burden, wherever that's from. And poorer people within rich communities. It's the poor in Manchester who suffer most from road traffic accidents, from burn injuries, from falls. They're the ones that suffer most. And it can be prevented. People with life-threatening but survival injuries, 6 times more likely to die. So there's nothing natural about this. This is in a structure. And the head of the World Health Organization recognizes this, and that we have simple, affordable, and proven interventions that save lives, and we must work on that. And whether you're going to do medicine or any health science, whatever, we can all work towards this. The doctors, nurses just deliver the care, but these are political and economic decisions that make people vulnerable. Just to think about search and rescue, if this building were to come down now, which maybe we thought it was going to, we wouldn't be sat here waiting for a search and rescue team from Nepal to come and help us. We would be rescued by the local fire station, and if they couldn't cope, then they'd get people in from Greater Manchester, and people from, international search and rescue teams have a very limited role. And it's good to understand these things to decide if you're going to help people. People often ask, what's the best thing to do in a disaster? Well, if you look at the Asian tsunami in 2004, lots of people went out, lots of things were sent. But the head of the Disasters Emergency Committee said that really just providing cash, unless you've got some special expertise that has been especially asked for, then just giving cash is the way. And that's my message to you. Unless and until you get trained and experienced in this area and you want to help, give money to a reputable organisation. But that's how you can do the most good. Remember, there's a veneer of civilization. It's remarkable how easily it cracks. But I've always been very positive. There are more resilient people than vulnerable, so don't worry. Certainly not too much. And when people my age tell you, oh, things were much better when I was young, they're absolutely right. Absolutely right. Whoever told you, absolutely right. Why? Because they were young then. Everything was better. I mean, so just say, yeah, right, okay. It's a good test for just how old they really are. And you will hear criticisms of international aid. And it's right, we have to be critical of it. It can distort economies, there's corruption, it can be inappropriate. And I know all the arguments, and I try and address them all the time. But one of my idols, Mary B. Anderson, who's an economist, she said, "It is a moral and logical fallacy to conclude that because aid can do harm, a decision not to give aid would do no harm." So doing nothing is never neutral. You have to think carefully about what you do. Finally, I have written a book which I'm happy to sign for people outside. I would just like to mention Gerald de Kerr and the risks that we all face. I was asked by the UN to go and do an assessment mission in Mongolia. There'd been a perpetual drought, there were health needs, and so I was to lead a team to go and assess what their needs were. The date of the mission was changed, and in the meantime, I was asked to go to Nairobi for the consequences of the Nairobi bombing in Kenya. So I couldn't go, and Gerard Leclerc took my place. And the helicopter he was in crashed, and he was killed. And nothing was in the news afterwards. There was no mention of this young man, a young father, no recognition of the work. And it set me thinking for many years that I should record it. Not to say, oh, I'll write my own obituary, and not that, just for people to understand the nature of the work, the complexity of the work, and that there are lots of good people just trying their best to make life better for some of the poorest and some of the most vulnerable, really in their darkest hour. Thank you very much. I know time's moving on because of the delay, but I am happy to take questions if we will have time. I thought somebody was going to say, are you sure it's 20 minutes a pound? And then
Thanks very much for the interesting talk. You talked about the difficulty of ethical decisions, and I was wondering whether they become easier over time, or even whether you perhaps develop a sense of objectivity about them and are able to look at them and say, this one's not as bad as the last one, or whether you develop a strategy for making them even, and just how your experience of those has developed in so many different circumstances.
Nobody's asked me that before. Do they get easier or harder? And it's both in many ways. Some get easier because they're more experienced. I remember as a very junior doctor, a consultant making a spectacular diagnosis of a rare condition. I thought, I can never do this. I don't know how you do it. And he pulled me to one side. He said, it wasn't that good. I've seen it before. And he said, just see lots of patients and you'll get better at it. And you'll know what's normal and what's abnormal. So I've found over the years, things have got easier for it because I know it's like that, but not always. I thought I got used to dead bodies. I remember in Haiti, in the middle of the town, almost having a panic attack with all the dead bodies. And I had to talk to myself and calm myself down. And I'm, old and grizzly. I'd been doing this for a long time, but it was surprising how I could still be affected. So the better prepared you are, the more you know. I always say, prepare, practice, have a plan. If you do that, then you'll get over that initial shock and you'll make things better. And also your decisions will have a point of reference. So you can say, well, they get harder because you see more and it's cumulative. I never wanted to be a sort of doctor who said, I get hardened to this. In many ways, I've got softer towards it. I find it, because I've got children and grandchildren, and you always see people that remind you of your own family. The most important method I use for these decisions is to share it. So it's not just you saying, well, we'll operate, we'll do this and that's that. No. In our prepare, practice and have a plan, we have a set of, these are the guidelines we will use for choosing people to go to surgery, set against international standards. And we will share the decisions. So I would say, I think we should do this. What do you think? And then people would say, well, yes, or no. But we make sure that everybody is involved in the decision. As team leader, many times you're given the casting vote, or people just say, well, whatever you think. But I think it's sharing it with people and not being gung-ho about it. It's not. They really are difficult. I see people in medical field give lectures on triage, and they're very black and white. You'll do this and you do that, and you'd rule those out, you would rule those in. I can clearly see they've never done it. When you actually do it and see the consequences, go back to the ward, and the ones you didn't treat first are now dead, and their relatives are weeping over the body. But you have to say, well, but they're equally people who got their surgery first and would have died otherwise are now sat up in bed and they're going to be okay. Yeah.
Hi, you mentioned about the Ebola epidemic in Sierra Leone and changing of the way they had to bury the bodies just because of traditions. And I was wondering, how do you find that fine line between a country's traditions that's been in place for hundreds of years and coming in as a third-party member who doesn't have those beliefs and traditions? How do you find the line between keeping them and then helping the country?
You engage local people. One of my first slides going back to Armenia was work with the local people. And you're quite right, there were international agencies went in and just started to, you can't do that. For example, they bought in black body bags. That's not culturally acceptable. People are buried in white. A simple thing, and so people would not use them, would not engage with the protective process. You need to work with the community leaders, and it's they that are introducing those practices. There've even been talk of, in those circumstances, putting anthropologists in with the emergency teams to help, given their experience of dealing with a range of cultures, to help them through. So it's absolutely right. It's so easy to come in and say, well, you obviously have to do it this way. But it was only when the international community got the Sierra Leonean healthcare workers to lead on those processes that the change happened.
How do you deal with people who might be disillusioned about humanitarian aid? And I'm thinking particularly in the last year or two and in light of a government that's deprioritised aid.
That's the government that's deprioritised. I don't get that feeling from the people, the people that I mix with. There will always be people who say, charity begins at home, and we have many needs here. My counter-argument to that is that I do it because I think it's a good thing. Full stop. Now, that's a philosophical, I understand the term is deontological approach to it. I'm not religious particularly. Well, I'm not religious, but I still recognise that I want to do good things. But even if you don't accept that, there's a huge payback to this country here, because people who go and respond to these disasters gain an enormous amount of experience that is brought back here. The Manchester bombing here, a lot of those who responded to it had experience of working in disasters overseas. They know how to deal with these issues. COVID, so many people in all the hospitals around the UK had deployed with UK Med or with MSF or with others. They brought all that experience. What we need to do is to make it easier to move between the two worlds. There's a problem in trying to maintain a career in whatever you do in this country and do humanitarian work overseas and then get back into your job. And so people either stop doing humanitarian work or just end up sort of roving the world from one humanitarian crisis to the other, which isn't good for them, isn't good for their skill base either, actually. So that's my answer to it. And I think we should just engage with other countries. If you look at the vaccine program now, we've done really well here. But it's a false idea to think that if we don't give vaccines to other countries, we'll ever control it here. Planes are coming in, it's coming in. We just have to vaccinate everybody. And I think it was the right thing to do to give vaccines to other countries. But even if you don't think it's right, it's the safest thing to do for us here. It's in our interest, our own selfish interest. Don't know whether it answers all of it, but that's the right. Some people you won't convince.
I was just going to ask about, because the majority of the people in the room are uni students and at that start stage of making career choices for the future, and you mentioned about the difference between those who are out and active in the field or could be active in the field in the future compared to those who are staying at home and making money and choosing to donate that money to effective causes to help in humanitarian emergencies. Yes. So I was wondering what you would suggest that us as people who are going to be making those career decisions in the future, what we should consider when thinking about either of those options career-wise.
Okay. There are certain principles that I've adopted and which I advise people. If you're going to really help people, then you've got to provide them, if it's personally, with some skill or facility that they don't have. So it's one thing to say, well, it'd be quite interesting to go and help people build houses or do things like that. they'll build their own houses. They'll, you know, after the tsunami, people went in and say, you know, oh, we'll build your boats for you. Well, who built the first one? They just need the money to buy anything. They'll build the boat. And so I know people want to give of themselves. I understand that. And it seems so detached to just give money. But I would say if you want to do it, then just get skilled in whatever it is and then see how that could help. Whether that be at home, because you can help humanitarian organizations by working in them. The people you see in the deployed to the field, it's the tip of the iceberg. There's a huge administrative process required to get there. And then fundraising as well to help people. They mentioned about the government and removing funding. Well, they get round that by having enough of your own funding to make your own decisions that you can deploy. I think there was another part to your question, was there? Or is that, have I covered it? No. Okay. I mean, MSF France, for example, are completely independent, I understand. They take no funding from outside. It's all done by donations, and they can deploy when and where they want without interference from donors.
Thank you for your talk. It was very insightful. I'm curious about your thoughts on the overlap between development aid and humanitarian aid, as you describe them. What do you think is the responsibility of emergency international response in setting up long-term systems in international environments so that they can be self-sufficient in case of future sudden onset disasters or conflict?
Yes, I think they should. If you look at the experience of MSF, for example, they've gone into many emergencies and their hospital just stays. The earthquake in Haiti, when I was there, there was an MSF huge tented hospital. It was already there before the earthquake. Yes, I think it should. I think you need to work with and engage with the local authorities. But by that, you have to draw people in and if necessary, employ people. It's got to be integrated. Otherwise, it's a parallel system which serves some function, but it doesn't address as well as it might the underlying problems. I mean, just on the health side, if we go into a country that doesn't have any sort of health system or a subsidized or national health system, if we go in and provide free care, we're putting all the local healthcare workers out of work. So in fact, we employ them, bring them in, work with us. It's absolutely right. It's hard to separate, and it's going to take a while, but we have it on our mind. In our standing orders for deployment, day one in country, what's your exit strategy? How are you going to hand over this to the local people safely and effectively? Because there have been stories of teams going in. I know of one team, who shall remain nameless, who went in, put a patient on a ventilator. So, you know, they've got the machine breathing for them. We're going home now, and we're taking our ventilator. There's an ethical. It wasn't us, but we did bail them out. But it's, so yeah, I agree.
That's fantastic, thank you. Can everybody join me in saying a huge thank you to Tony for a really inspirational presentation?
Thank you.
Just a reminder, we'll let Tony exit.
That was important.